Hello and welcome to our webinar today. Thank you so much for attending our webinar. That is a partnership between multiple associations. My name is Spencer Giese. I'm a research and education specialist here at KUI, and we're excited to be bringing this to you in association with the American College Health Association and the National Consortium for Building Healthy Academic Communities. We recognize that COVID-19 is a challenge on all of our campuses and a hot topic that we are discussing on a daily basis. Today, we hope to share with you resources that will help you in your work on your college campuses. To give you a brief overview of what we'll be speaking on today, we'll be sharing an overview on the current state of COVID-19. We'll be providing practical considerations for your campus, and we'll be providing housing and residence life considerations. As we go through this webinar, there's a Q&A button on your Zoom menu, and you have the ability as an attendee to submit your questions via that Q&A tab. Thank you again for the overwhelming response to registering for this webinar and attending this webinar. We currently have over 600 viewers, and we're excited to have you join us for today's session. We will be recording this and posting it on social media, YouTube, and emailing out resources to all attendees and those who registered for the webinar but were unable to attend. So please know that we will be sharing these resources if for some reason you have to step away or are unable to attend. So first, we'll start with James Jacobs. If you could just introduce yourself, share about your expertise in this field, and we can discuss this topic.
Thank you, Spencer. It is a privilege to join my colleagues on this panel today, and I think we're very appreciative of the collaboration between organizations in the time of this extraordinary national and international event. I'm a physician at Stanford University. I am waist deep in our own institutional response to COVID-19, but I'm also here today representing the American College Health Association, and even though I'm here because of ACHA, I just want to make the disclaimer that I don't claim to speak on behalf of ACHA or Stanford University necessarily. Something else that I find particularly remarkable about this particular webinar is that at least at our institution, and I suspect at virtually every institution, the key partner in managing institutional response has been our residential and dining enterprises, and I very much respect and appreciate the work that you will do as professionals in this arena. My remarks are going to provide a high-level overview of COVID-19. Probably won't be breaking any news that you haven't heard through the media or through your own campus resources, but just to kind of bring us all into the same page. Coronaviruses are not new. It's a family of viruses that we've known about for a long time. They're ubiquitous, and we've traditionally known them to cause only mild respiratory illnesses. Most of us have had a coronavirus illness in the form of a cold or sore throat, and they're even on the traditional respiratory panel that we might do during flu season or in investigating other respiratory illnesses. But with the emergence of SARS in 2003, we came to realize that some coronaviruses can be dangerous. This was followed in short order by MERS towards the end of the first decade of the 2000s, and then now with COVID-19. So the ubiquitous viruses are not famous, but clearly SARS, MERS, and COVID are famous, if not infamous. Something that's not unique to coronaviruses, but of note, is that they typically are spread by zoonotic means, and zoonotic is just a fancy word meaning that a pathogen can be transmitted from a non-human species to a human. Our current saga with COVID started in late December, when a cluster of unusual cases of pneumonia were noticed in Wuhan, China. Within a few weeks, the cause of this pneumonia was identified as a new virus that was initially named the 2019 nCoV. Fast forward approximately a month later, and the virus was renamed the Severe Acute Respiratory Syndrome Coronavirus 2, or SARS-CoV-2, but we're referring to it by the name of the disease that it causes, COVID-19. Apparently, the WHO is not going to use the word pandemic anymore, but we've now been weeks into WHO's declaration of a public health emergency of international concern. As mentioned, COVID probably started through animal to human transmission. It's still a point of controversy. With MERS, it's believed, it's quite certain that transmission started as a camel to human zoonotic illness. With COVID, whether it's bats or another animal is still being debated. But the what's most relevant is that there is now overwhelming evidence and proof that we have human to human transmission, and that's what's causing this to be such a significant pathogen. In the United States, and I do apologize that my comments are focused primarily on factors pertinent to the U.S. Right now. For a while, we just had this, we had scattered cases, and now we clearly are having outbreaks. The county that I am sitting in at this moment is considered a hotspot. Clearly, the Seattle area is a hotspot, but all over the country now we're seeing outbreaks. As the outbreaks start getting closer and closer, we'll have epidemic, and we, by definition, are in a pandemic, even if we're not using the word, because there are outbreaks and epidemic level transmission occurring across multiple continents. As you are likely well familiar at this point, most people, maybe as high as 80% of folks who are infected with COVID-19 either have no symptoms or they have mild respiratory symptoms. Less commonly can be noticeable headache, muscle aches, diarrhea. But somewhere in the of approximately 15% of cases evolve into severe disease, primarily lower respiratory pneumonic conditions, and then a subset of those are going to develop lethal complications. Moving on to a little bit about where we stand as of today. I gave a similar presentation on February 26th, and so I'm showing the numbers for comparison. In the United States, there's now 30 confirmed cases of travel-related COVID infection. But what is particularly concerning is a couple of weeks ago, we only had 2 suspected person-to-person cases of transmission. And as of yesterday, I'm not sure about today, but as of yesterday, we had already jumped to 20. And I suspect by this time next week, we'll be in the many hundreds, if not thousands, due simply to increased amounts of testing that's now available. A couple of weeks ago, we still were at 0 deaths in the U.S. Yesterday it was 10, but I understand that we're at 12 as of today. For those who haven't seen the map on the right-hand side of this screen, it's a fabulous resource that's posted by Johns Hopkins University. It doesn't have a lot of practical value for us on our campuses in the U.S., but it is a magnificent piece of work, and a link to that map, which is updated in real time, is at the end of my slides. So what are we doing? As I mentioned, much of the response on our campuses is not medical, fortunately. It's a lot of environmental factors. I think key is that this is an institution-wide response. This cannot be the responsibility of the Student Health Center or just the housing office. I hope that you all are in environments where every functionality of your university is represented on your emergency response teams, and I'm very fortunate that is the case at my institution. Foremost, and even though lots of folks in the public might not want to believe us, hand washing is the overwhelming most important mitigation strategy for COVID and many other infectious entities. But hopefully we're also continuing to emphasize coughing into the elbow and other risk reduction strategies, just as we were already doing for flu season. The most social disruption for the moment is occurring because of our efforts at social distancing, whether that be self-isolation for persons who have mild illness or significant exposure, drastic changes in work from home policies, restrictions on gatherings. Many universities are canceling events, refusing groups to enter campus, travel restrictions. Initially were just international, but many of our institutions now have domestic travel restrictions. And I believe that my colleagues on the panel will talk about other forms of non-medical intervention. For those who do become ill, the primary response is supportive care. So whether that be something to help with fever, something to help with cough, because at least as of this moment, everything here is changing hour by hour, but as of this moment, we don't have specific medical countermeasures, although there's very encouraging news about the antiviral medications that are being tested in China. And then, of course, we hope that sooner rather than later a vaccine will be available, but it's not going to be available during this school year, unfortunately. Some of your campus colleagues may have questions about what is the big deal about social distancing and some of these other strategies. And it's really well represented on the graph on the right-hand side of the screen. COVID is so infectious that there would be the potential that huge amounts of the population could be sick at the same time, which is represented by the peak of the purple curve. And if 15% of the population is significantly ill, our hospitals and other healthcare, other elements of the healthcare system simply would implode under the weight of those numbers. So even if we can't do a lot to prevent people from being infected, we want to prevent, we want to slow down that process, which is represented by the lower hump on the shaded curve, so that even if ultimately the same number of people end up being infected by COVID, we want to spread that out over as much time as possible in order to reduce the impact on the healthcare system. So near-term considerations, and these are in no particular order. We're seeing blame and discrimination on our campuses, and I hope that we all have very firm guidance in place to help mitigate that. Spring break travel is a big mess. Some of you are going on spring break today. Others of us have spring break happening later in March. And it's not so much that we resent people going on spring break. We're more concerned about them coming back. Other travel, as I mentioned, is being restricted or prohibited. Campus visitors are an ongoing concern for many of our institutions. We have tour bus after tour bus after tour bus that come to our campus. Fortunately, we've been able to stop that for right now, but this is also the season for recruiting grad students and having lots of other visitors, and it's an ongoing concern. Major disruption of international programs, particularly study abroad programs. For those of us on quarters, most of us have stopped the study abroad programs for spring quarter. For those of you on semesters, it's a particularly severe disruption. Trying to bring students back to campus or figuring out how they're going to complete their program electronically. We're going to be seeing more and more staff and student absenteeism. And of course, none of us wants to go there, and it's on our list, but it's on the bottom of our list, is the potential for campus closures. Some of you will be aware that the University of Washington announced this morning that they are canceling all in-person classes for the rest of their current quarter, and mandating virtual completion of the quarter. I won't be surprised if we see more of that sort of thing. And then finally, just to acknowledge some of the unknowns, even though most of the news has and data had centered on elderly, chronically ill populations as being most vulnerable to develop severe illness from COVID-19. There probably are other populations that we still don't have a good understanding of. Still some controversy about the latency or the time between being exposed and the time getting sick. And then even once you've gotten better, we're not entirely clear how long you can continue to shed virus. Fomites, which is a big topic for your organization. They're hard surfaces, keyboards, tables, doorknobs. We don't have a good understanding of how well the virus can persist on fomites. And then finally, I'll mention seasonality. We always have assurance that flu season is going to come to an end. Sort of at the end of an academic year, often. We have no idea whether there's a seasonality to COVID. We are hoping there is, but we don't yet know. And I do want to mention, as on my last slide, there are I've listed a number of links that that I find very helpful in providing information, not just about the medical aspects of COVID, but about many of the other topics that are being discussed. And I would bring to your attention with some amount of pride the next to the last resource I've listed here. It's the ACHA guidelines preparing for COVID-19. This was written by an ACHA task force that came together 2.5 weeks ago, dusted off prior pandemic plans, and have published now some COVID guidelines. And they're available for free as a PDF from the ACHA website. And even though that document does not provide a step-by-step menu for how your campus should respond, it's going to talk about most of the important categories. And if you find a category that your campus isn't addressing, hopefully that document would stimulate discussion on your campus to make sure that area is addressed. Thank you very much for this opportunity, and I'll turn it back over to Spencer.
Oh, Spencer, we can't hear you. You might have hit the button on your cord.
All right. Are we back?
Yep, we can hear you.
Okay, excellent. Jim, thanks again so much for joining us. I know that your schedule has been quite hectic as you're helping many campuses, many associations respond to this. So thank you again. We're going to move to our next speaker, Kat Marriott from Building Healthy Academic Communities.
Okay. Thank you so much, Spencer. And thank you, Jim, also for your presentation. And I just want to reiterate that those resources on that last slide that Jim presented are truly invaluable, and that even though we're talking about these issues and this topic today, that really everyone should if they have specific questions, reach out to those valuable and reputable resources that are out there, and especially those ones that Jim pointed out. So what I'm going to be talking about today are some practical considerations, and some of this is, if you will, common sense that we hope that you will be taking into consideration and utilizing. So first things first, I'd like to state that it's important that we not panic. For the vast majority of you out there, for the most of the American public, the risk of COVID-19 is very low. We know currently that in California, Washington, and Oregon, we do have community-associated spread of COVID-19, and people in these areas are at an elevated risk, but still the risk from general exposure is very low. Healthcare workers caring for the patients in these particular areas are at an elevated risk, and close contacts of people with COVID-19 are also at an elevated risk. And travelers obviously returning from the affected countries are at an elevated risk, but the rest of us are still at a relatively low risk. For anyone who has not looked into it, or if your organization isn't sharing this information, these are the current CDC announced travel restrictions. In currently China, obviously, where the infection has originated, and Iran, we have widespread ongoing transmission, level 3 travel restrictions, and there's currently no entry allowed into the United States from either of these countries currently. Italy and South Korea have, again, widespread ongoing transmission, again, level 3 travel restrictions, and the CDC is recommending that all travel to these countries are avoided. Currently in Japan, there is sustained community transmission. A level 2 travel restriction is currently recommended, and it is recommended currently that any travel currently planned to Japan is postponed. And further, the CDC is recommending that all travelers should reconsider cruise ship voyages into or within Asia at this time be postponed and not, if you will, planned for this time. So it's hard, aside from the large map that Jim showed us, it's hard to take a snapshot of what's happening globally, but these graphs show just a little bit what we do see, and the graph on the left is showing what's happening in China up until this particular graph was February 20th. What we do see is a steady decline in the number of confirmed, clinically diagnosed, and suspected cases of COVID-19 that is happening currently in China. But internationally, we are seeing a bloom or an increase in those cases internationally. So when we talk about the current COVID-19 outbreak, virologists, epidemiologists, and scientists are looking at a couple of different scenarios in terms of predicting or examining what could be happening now and what could happen in the future. There are a few ways that the outbreak could take a turn for the worse. Then in one scenario, China could be unable to contain the virus spread, which currently that does not appear to be the case. The new coronavirus could spread in countries with very weak health systems. Those countries, unlike the United States, which has a very robust, strong health system, the same with China, that might be the case of what's going on currently in Iran. It's hard to tell at this moment. It could be found that the virus is actually deadlier than it seems right now. Again, this is just a possible scenario. And one possibility is that the travel bans could isolate countries, spread xenophobia, and exacerbate the outbreaks, especially if we have the situation where people are hiding and or denying what their travel has been. That's definitely a situation that experts are keeping a careful watch on. So as I mentioned, currently the epidemic in China appears to be being contained, and the cases are on a decline. It appears that appropriate measures are being taken, and therefore we are seeing a decline in the number of cases. The graph on the right kind of shows those the cases again. This is at least through the month of January, and the important data points or the events that have happened on the spectrum or along the timeline that has led to both the increase, the recognition of the infection, and then the decline in the number of cases. So the scenarios which could unfold that would either not necessarily prevent, but at least reduce the further explosion of a pandemic. Again, if China is able to contain the virus, which that it appears at the moment, that is what is happening. Local clusters of the disease in other countries don't expand or bloom. Again, what we're seeing at the moment in the United States is regional epidemics. Whether that continues to spread and or these clusters begin to increase, we're not certain. Right now, it appears that that we have not yet hit the peak of the epidemic within the United States. But how far or how long or how expansive that epidemic or those peaks are, we're not really sure yet. As Jim mentioned, what we do not know is whether the virus will continue to spread, or there's a seasonality associated with COVID-19. If the virus can't spread well in those countries with hotter climates, or if it is negatively affected by seasonality changes, then we will see a decrease in the pandemic. Again, these are things that we don't clearly know at the moment. And if we learn that the virus is not as deadly as it seems initially, what we do see and what we do know at the moment is that the severity of the cases and certainly the deaths associated with the cases currently appear to be in the elderly and other comorbid situations, meaning individuals that are already suffering or dealing with another ailment, another disease. So these two graphs show you just a little bit of a snapshot of what we're talking about. In generally young or healthy individuals, we see disease, onset of symptoms, admission to the hospital, confirmation of the infection, and general recovery from the symptoms and eventual discharge, whereas the deaths are predominantly in the elderly, the age of 60, and this is a somewhat arbitrary cutoff, but those individuals 60 years and older appear to be at the highest risk, and this is where we're seeing the bulk of the fatal cases, both in China as well as in the United States and in the other countries. So as Jim mentioned, and as a infectious disease researcher myself, the best thing that we can talk about at this particular point is practicing good hygiene. Cover your mouth and your nose when you sneeze or cough. Cough and sneeze into your elbow or your armpit. Wash your hands regularly with soap and water. Use alcohol-based hand sanitizer, especially after coughing and sneezing. Avoid close contact with people who are sick. And avoid contact with people. If you can't avoid contact entirely, keep a safe distance from them in order to reduce the risk of transmitting germs. And this is applicable not only to coronavirus infection, but also any of our seasonal respiratory transmitted infections. Stay home if you don't feel well. If you're seriously ill, seek medical advice, but stay home. Stay away from healthy individuals. Don't spread the infection further. We recognize and we see a lot of anxiety, some panic. We see these, pictures of individuals walking around with face masks, and even more, I would say, critical or more heightened response. It's important to stay informed and use reputable sources such as the CDC for accurate information. There's no need to panic, but a little bit of anxiety about this situation is probably normal at this particular point in time, because coronavirus is an unknown infection. We don't know a lot about it, but what we are learning about it, we do see that it's very similar to the other coronavirus infections that we've seen in the past. Try to maintain a balanced perspective. The media attention right now about the coronavirus outbreak is very high. We see it on the nightly news, and every time we turn on the TV or whatever news source that you're looking at. And of course, we're only hearing about the negative events. So this can certainly lead to a heightened perception of the risks. Most importantly, one thing that we want to advocate is take care of yourself. Get good sleep and exercise, practice relaxation, and try to maintain a healthy lifestyle. This will not only help you stay healthy, but will also reduce or add to the ability of managing anxiety and stress that is right now being caused by what's going on. So in terms of an institutional's response to this particular outbreak, and hopefully this is happening at all of your institutions. I certainly know that it is happening at mine. Jim talked about his particular response, or the particular response at Stanford. One of the biggest questions, or the very first questions that came out, is where are your people? Where are your student groups? Where are they studying overseas? Which of your faculty are being affected by this particular outbreak, whether they have been, or they are in China or in these other countries? How do we protect them? How do we get them back to the United States if they're not already returned to the United States? And then when they return to the United States, what is your institution's protocol? Every institution ought to have an emergency preparedness plan. And these plans honestly should be following best practices discussed by a committee in order to both monitor the current situation and update the individual students, faculty, and staff at your institution. And these, the people involved not only should be key administrators, but appropriate medical staff, public affairs individuals, deans of students, campus housing, and the international office. All of these people need to be involved. If you don't have the involvement from these people that are directly a part of your institution or your campus, your local individuals within your community and whatever county or health district that you are associated with should and will be there in order to help you and your campus. As far as any specific procedures, what we know about coronaviruses in general and what we know about this particular coronavirus, there is no special or different sanitizing or decontamination procedure that is being recommended. Just your standard run-of-the-mill procedures really should be followed for cleaning and disinfecting, especially around your campus. As Jim mentioned, we don't know a lot about the transmission of the virus through fomites. So commonly touched surfaces like doorknobs, desktops, keyboards, etc. We can only assume that these are potential sources of the virus. So cleaning these or paying close attention to these surfaces is certainly not a bad idea. And whether we're talking about the common cold or influenza, these are definitely areas that we can and should pay particular attention to. As Jim mentioned, one of the biggest questions or the most pertinent questions that is being asked right now is, at least for the institutions within the United States, spring break travel. I get questions not only personally, but through BHAC. What should we do about spring break travel? And should either students and or faculty and staff travel for spring break? And the answer really is it depends. Depends upon where the planned travel is and how many people and what the activities involved. There is clearly no travel that should be happening or occurring to those restricted countries. If individuals travel there, it is very likely that those individuals will not be able to return to the United States. You should consider the risks and be aware of potential precautions. It is not unlikely that following spring break, individuals will be asked where their travel was over that spring break, and what their general exposure was to potential cases. Self-quarantine may be requested, and depending upon where your institution is, it may be required, or depending upon where that travel was over spring break. However, we want to state that it's not widely recommended that all individuals be quarantined no matter where their travel is. It needs to be taken on a case-by-case basis. And right now, the general consensus is a 14-day symptom-free quarantine period appears to be sufficient in terms of making sure that an individual is not infected with coronavirus. But again, as we're learning more about the outbreak and the infection on a day-to-day basis. The other question that is coming up is about international students. So it's not just about American students traveling outside of the United States, but international students, specifically Chinese students, coming into and or being personally affected by this particular outbreak. It is some information has been telling us that up to 60% of the Chinese international students are being directly affected by the virus outbreak in terms of negatively affecting applications to universities, visa applications, and then the mobility, their ability to either leave China or enter into other countries. Blocked travel from and blocked entry to particular countries is being demonstrated on a daily basis, and then visa applications. And the implications to our institutions, as Jim mentioned there, you know, we are already witnessing in the United States institutions being negatively affected by this, either reducing or following procedures in order to eliminate in-person teaching and moving entirely to online-based or digital classrooms. And some institutions, especially in those areas that are highly affected, both in the United States and in other countries that are being affected by this outbreak, there's a prospect of losing entire semesters or more of the institutional learning. We are looking currently at Australia in order to understand the impact that this outbreak might have on not only international students, but on the impact to the institutions in general. The institutions in Australia rely very heavily upon Chinese international scholars, and right now, unlike the United States, the institutions are just now returning from their summer break. Many of those institutions have been unable to bring in those Chinese international students that were already enrolled or in the process of starting those courses. And the impact to those institutions is really only now just going to be being observed. So we're watching Australia very carefully in terms of what can be done in order to address not only the outbreak, but the impact that outbreak has upon the institutions. As I mentioned, they're heavily reliant on Chinese international students for their institution's income. So many institutions are beginning online course delivery or providing intensive courses, meaning condensed or not prolonged semester courses, and having to make special arrangements for particular events for the institution. Obviously, refunds and deferrals for those individuals that can't make it to the institution at all. Providing as much information that they possibly can, and supporting those individuals that are negatively affected by the outbreak, whether they be extensions, deferrals, could be financial support, special housing, all of the above. And obviously, what we don't know is how far, wide, and how deep the impact of this outbreak is going to be. But we certainly can imagine that the impact could be quite deep. Mr. Alan Ruby from the University of Pennsylvania has been quoted to say that the financial impact will be shaped by how dependent your institution is on tuition and revenue, and your ability to respond to the outbreak on your particular campus. With that, I think we're turning it over. Yes.
Yes, Kat, thank you so much. That was such excellent content, and I know we have had many questions flowing in that we'll be getting to shortly in our Q&A portion. But before we get there, I want to invite Dr. TJ Logan to step in and talk to us about some housing residence life considerations when it comes to COVID-19. So,
Sure. Thanks,
TJ.
Spencer. First and foremost, I want to thank and acknowledge Jim and Kat for the content that they provided. I think, really getting our arms wrapped around what's happening out there from a factual basis is helpful for a number of us from a practitioner basis who are on the front lines trying to work through some of these things. And what it's made me think of as we've gone through the process is that a number of us that are sort of neck deep in this on a daily basis, trying to manage this on our campuses, are dealing with this dynamic and balance between fact and feelings quite often. And there's this acknowledgement that these facts are going to take us so far, and then we're going to have to be considerate of PR challenges. We're going to have to be considerate of the feelings of parents and families and roommates. We're going to have to be considerate of balancing an ethic of care. I've been asked to come a little closer to the mic. Hopefully it's a little bit better. Balancing this ethic of care between the communities that we are supporting outside of our residential community and the communities that we are supporting that is our existing residential community. And so as I've looked through some of the questions throughout the chat here, I see that the reality is we are in a diversity of situations. Some of us have students on spring break right now. Some of us have students that are about to go on spring break. Some of us have international campuses. As an example, we have a campus in Rome that we've made a lot of decisions about. Some of us have study abroad programs, some of us don't. Some of us have to be thinking about when the semester ends, what are our students going to do who are international students who may not be able to return home. And then a lot of us are just in the very early stages of this thinking about what happens when somebody has symptoms on my campus. And I think that we need to be more broad than that, thinking about pre and post syndrome. I don't know if I can turn my mic up any further. I'm seeing some mic pieces. So hopefully, does that help at all? Perfect. So I wanted to talk just generally about sort of those pieces and the notion of the balance, and that whatever we talk about today, I think it's critically important that you understand the context on your own campus, the context of your own university community, and the surrounding community that you're working with. I want to start a little bit in terms of some facilities planning pieces and some things to think about. And I don't want to read the bullets to you because that's really not helpful to you. I'd rather just sort of talk a little bit about some of the things that I've heard and seen both on the online communities and in conversations with colleagues around the country in terms of best practices and things that we need to balance. As an example, I think it's critically important for all of us to know what our occupancy is right now. You know, if I were to ask you at this moment, how many beds do you have open? What type of units are those? How many of those are isolated? How many are singles? What type of bath configuration are those? Most of us can answer those questions. All of us should be able to, but most of us are able to do that right now. I think there are deeper level questions that we need to ask ourselves from a facilities planning perspective that maybe we haven't thought of. As an example, if you have an isolated apartment unit, one of the questions I was asked the other day is, does that have air handling that is just within that unit, or is it sharing with the rest of the residential building if you're looking for people to self-isolate in a facility like that? And so these are considerations from a facility perspective that I don't know that we've considered up until now. We've looked at our facilities from a room type perspective, but I think it starts to become important to think a little bit deeper and think about all the implications of that. Not because the facts tell us that that makes the most sense, but because the feelings are informing the way that we have to respond to the public, the way that we have to respond to parents and families, and being thoughtful about those things on the front end is critically important to us. I would also say that we have to know our systems in terms of our capacity to be able to respond to student events and things like that. It's been recommended by the other folks today that we know where our students are, as an example. And some of the questions that I've seen in the chat are, how do you do that? Who does that? At the end of the day, what is your capacity and what is the capacity of your campus to understand where all students are at any given time? Right now at Temple University, we know where every single student is from our Rome campus. We know where they've been during their spring break. We know where they are in transit back to Philadelphia or not. We know what their flight number is. We know whether it's been canceled or not. We know if they have somewhere to stay for self-isolation or not, where they're planning to stay, whether they've checked in or not. That is herding cats, especially when you throw in things like emotional support animals and elderly, immunocompromised parents that may be trying to take it. There's a variety of issues that we're tracking. And so I think that really helps to roll us into this notion of communications and other key players and being comprehensive in this. And my one piece of advice in that I've learned, because again, I've been very neck deep in this over the last 2 weeks or so. It's been a 24/7 venture for us in a very collaborative way, is that we have to recognize that this is a very fluid situation. And we saw some of this in some of the facts that were brought up today, that countries are moving in terms of levels and in terms of severity. The facts are changing on us on a daily basis. And from a communication perspective, we are not used to communicating in fluid situations, or at least that's not usually our standard practice. We like to meet in committees. We like to come up with a concrete answer, and we like to issue that concrete answer. And I think that's detrimental to us in these types of situations. And what I found is that we've got to be very thoughtful about the way that we're communicating on the front end, and recognizing that situations are changing on a regular basis. So if we were to say to a student today, you're going to return to campus after spring break and everything is okay, that may change tomorrow depending on what part of the country you're in. And so being thoughtful about not just the way that you word that, but giving them the notion that this is a fluid situation and updates are going to be forthcoming and going to be changing as we go. The other thing that I would say about communications and best practices that I've seen thus far is be very thoughtful about messaging and what that messaging is with regards to preventative behavior amongst your community and what that says to behavior of your staff. As an example, if you were to send a notification to your entire campus that talked about taking preventative behaviors to ensure that you're not contracting or spreading anything, what is that going to say to your housekeeping staff who has to care for a residence hall with 1,000 residents in it? Are they going to come back to you and say, am I in danger just by virtue of my job? And so thinking about strategically the way that you're communicating with those folks. What is a best practice out there for our facilities and housekeeping folks is that we have them cleaning high touch areas. They're cleaning panic bars, they're cleaning stair rails, they're cleaning door handles, they're cleaning tables at the library, things like that, or in study spaces in residence halls. But that we're also letting them know these facts that we know about being very, very low risk, and we're letting them know that we don't have any students that are sick, and we're letting them know that students are being screened pre and post on flights from level 3 countries. All of those types of things that we need to make sure we're reassuring them, but also giving them the tools that they need to do that work within the residential facility as they go along. And reassuring them that, again, you can't ever guarantee somebody is safe, but that the precautions are in place and that there's very, very low risk, as Kat sort of alluded to. And just being thoughtful of that. The last piece that I would talk about a little bit is particularly in communications, and this was alluded to with Kat and I think with Jim, was this notion of having an incident response team or having a full campus team. While housing and residence life professionals are often on the front line of this and are often the place with the highest impact, particularly as students are returning back home from different locations or not able to leave at the end of a semester, involving, and not just your local health officials or looking at CDC information, but involving folks at all levels of the institution is a best practice. Do you have an incident response team or an emergency response team that is meeting on a regular frequency, that has representation from University Communications and Marketing, that has representation from a legal perspective, that has representation from the provost's office because of the academic implications and what's changing on that side in terms of potentially doing things remotely, and that has representation possibly from a care team representative. So having that variety of folks around the table, and again, keeping in mind that this is fluid and changing at all times, and knowing what everybody's role is in that, and empowering people to make decisions as they go is critically important. And then lastly, language is critically important. What we have found is that there is a big difference between talking about quarantines, self-isolations, self-monitoring. Those are all very sort of different things by definition. And helping not just your internal staff, but your students who are returning to your campus or leaving and coming back to your campus, or international students on your campus, understanding what are the differences between those terms. When you say self-monitoring, people will have the same level of emotional response as you would to quarantine, yet those are very, very different things. And we have to be thoughtful about the language that we use and how we describe the things that we're doing as we move through this process. So I know that we have a ton of questions in the chat box about very, very specific issues, and I'd love to take some time to jump into those if we can.
Excellent. And thank you, TJ. As TJ alluded to, we do have a question and answer box. So if you take a look at our next slide, so we are able to take questions for the audience. We've got about 15 minutes or so that we're going to work to do our best in terms of doing some question and answer with our panelists and cover some of the salient and common topics that we're seeing through question and answer. We have Michael on the line as well. Michael and I will be working hard to moderate some questions and share those with our panelists and see if we can provide you all some answers. Before we dive too deep into that, those of you from the ACUI Association, as a reminder, we do have an online community forum that many of these topics, when you're wondering what other campuses are doing or what resources are out there and that can be shared, I highly recommend continuing to use our online community to post questions and really use some groupthink and source questions from and answers from other campuses. Mike, are you there? Do you have any questions you see that jump out that you'd like to ask to start us out?
I'm going to start off with a question for Dr. Jacobs. Jim, what about handling students with underlying health conditions? Should we put together different sets of advice for those students than for other students?
Thank you, Dr. Huey. This is a very live topic for our campus, and it's one that I feel is almost impossible to do through FAQs or broad emails. What I have asked students in that situation is to contact our medical director for one-on-one counseling. And the situations have been anything is that even though institutionally people are finally starting to come around to our instructions not to use masks at this time, possibly there are some students for whom providing masks would make sense. They can't buy them on their own anymore, and so maybe we need to loosen up our policy for students with certain immunocompromised or other chronic conditions. But I do think it's a one-on-one advice rather than global advice. And of course, we also have students who are saying, I want to get out of here. I want to go home, whether it's domestic or international. And it's not at all clear, as someone else pointed out, I can't guarantee your safety on the airplane between here and getting back to London to the safety of your home. And so there is some risk that we can't reduce, even for, and especially for some of these more vulnerable students. Although I think we didn't allude to it here, but young adults seemingly are amongst the least vulnerable to COVID-19, but certainly when you throw in immunosuppressed conditions and so forth, it's not clear yet what the data are going to show. Mike, you're on mute.
And I'm back. Another question for you, Jim, Dr. Jacobs. A faculty member asked one of our attendees to define sick for them. So there's some things that are easy. Sneezing, if someone is sneezing, not necessarily due to an infectious disease. But what about some of the more systemic type symptoms like fatigue and aches, what we call myalgias? Do we have any suggestions for the attendees on where to draw the line about who is sick enough to start asking historical questions about travel and other exposures?
So up until a couple of weeks ago, this was relatively easy because we could restrict it to travel from or through, basically through mainland China. And then for another few days after that, we were able to continue using travel as a specific risk factor. But now there's plenty of places in the United States where you're probably at as much risk as you are in various international locations. And so we've, even though travel can still be a red flag, it certainly doesn't narrow the possibility that those symptoms, all of which overlap with sinus infections and seasonal allergies and the usual coughs and snorts and sneezes that all of us have at various times in the year. And so it's that is now also coupled with progressively increased capability to test. And so I think we're going to see an explosion of cases, not necessarily because they're new cases, but because I can't distinguish a sinus infection from a sinus infection that might be caused by COVID. As testing becomes available, that person may end up testing positive for COVID. They're not any sicker than they would have been last year with the sinus infection, but now we do have to treat them as a confirmed case. The complex, simple answer to the question, Mike, is this is a very difficult challenge now, and those same symptoms could be benign. And actually, even if it's COVID, it's probably benign from a medical point of view. But all the isolation factors are going to come into play. So sick is sick, but can't tell you whether sick was COVID or not.
All right. Question we've been seeing a lot about ventilation. Is there evidence to support, or is there evidence showing that COVID can be transmitted through common ventilation systems?
All of us are anxious to jump on the answer to that one. I'll just start by saying I'm not aware of any evidence one way or the other.
And I would just say that all that we can do at this point in time is take the clues and the information that we have from the other coronaviruses, and there is not strong evidence that is a readily that is a transmission that is that happens readily with the coronaviruses. So again, these are educated guesses that we are that scientists and researchers are taking, but it is based upon facts that we know, especially from the other related coronaviruses.
And I'll say, when I mentioned contained air handling, one of the things I talked about was facts versus feelings. And again, the facts may not support that. That's one of the things that at Temple, from a feelings perspective, when parents, families, communities say, you're bringing students home from Rome and you're self-isolating someone in an apartment, we're able to say, yes, but. And it helps with the feeling side of things more than anything else. Although even if the evidence isn't there, I think that's what you need to be thinking about is here's what the facts say, but what is the PR side of this as well as you make decisions on your campus.
This is a question that could apply to any of you, be answered by any of you. We're heading into a time when a number of our campuses are getting involved in tournament play, and specifically in the United States in basketball and what we call March Madness at all of our different division levels, from large institutions to the very smallest. At my university, Emory University, we have round one of Division III NCAA men's basketball tonight. So what kind of advice should we be giving to administrators on our campus, to our athletic department, about safety at mass gatherings and specifically sporting events, whether they are on our campus or our athletes and coaches are traveling to other campuses?
I know that Johns Hopkins has announced that they are not going to allow audiences into their basketball stadium. I believe for the tournament, but I don't necessarily have the details. I know the NCAA is even thinking about having audience-free March Madness. I have no idea how far that discussion is at the moment, but I think the same principles apply that we've been talking about. Make sure there's opportunities for hand washing. Make sure there's opportunities for social distancing. And our county is now defining social distancing as being an arm length away from another person. If the stadium is so packed that everyone is shoulder to shoulder, the risk just is going to go up proportionately. So it can't be business as usual, where we pack the stadiums with ravenous fans. But there may be an opportunity for compromise, something between ravenous and empty stadiums. Again, that's an opinion. That's Jim's opinion, not Stanford's opinion.
And I would say too that again, it depends upon where your community, where you are in the community, and what's happening in terms of the cases and outbreaks that are happening either in your state or in your community. We currently have, there are several states in the United States that do not have a single confirmed case of COVID-19. So should the large sporting events or the large gatherings, public gatherings in those states be either be canceled or be have spectators eliminated? I personally, I think that that's bordering on a knee-jerk or a panic reaction. However, as Mike mentioned, we have to take into consideration the public relations aspect of the situation and not just the science of it. So if it puts people at ease, as opposed to heighten the panic or heighten the situation, then consider it. However, there really is not a lot of evidence or data to suggest that reducing or eliminating these particular events in non-endemic, non-outbreak areas really does anything beyond let people feel good about the situation.
Here's a privacy question. Along the lines of FERPA and HIPAA, should you on your campus get into a profound surge situation where many students with illness or potential illness are presenting and or contacting the student health system remotely, under what circumstances would you allow non-licensed personnel to begin fielding some of those questions or taking some of those health histories? Is it enough to simply have them sign a confidentiality agreement? Do we have different rules when we are in an epidemic situation than we do when we are not?
Wow.
I think this is one where the details really matter. What are the volunteers going to be doing precisely? If they're doing crowd control, if they're moving if they're escorting a patient from one place to another, if there's a lot of ways that volunteers can be involved without having to know even the person's name. But this is treacherous territory, and I would want and particularly for those of us who are accredited, there's additional layers of a responsibility. But I think most of all, the students or the patients need to understand that this is happening, if indeed it's happening. As long as there's transparency and disclosure, I think we can get away with a lot. It's not getting away. It's utilizing the resources of our community who want to help. But I think we still have to maintain an extremely high threshold for confidentiality, especially in this situation where we're seeing so much xenophobia and fear. It's even going to be interesting to see how our local health departments manage the issue of naming names for positive cases. Although it's pretty obvious when Johnny is no longer in the dormitory, and Johnny's had a cough for the last few weeks, and now Johnny's not back in the dorm, and a positive case has been reported. People can put the pieces together, but I think part of what we do well in college health, and also I think in student affairs and in college in general, is helping to protect the privacy of our students, and we have to be extraordinarily careful, even when everyone's heart is in the right place.
And I would just add to that, I mean, HIPAA is HIPAA. It doesn't matter whether there's, an outbreak going on or not. It's so just to reiterate what James said, is that confidentiality, we all have, diligent, responsibility. However, there are certain questions and certain things that can be asked of individuals without going into those sticky areas of confidentiality. Just notifying or asking questions about travel is that's kind of one of the first steps in terms of identifying these individuals that might be at risk. But as I said, just because we are in a potential emergency situation, it's not that HIPAA rules are relaxed.
Well, I know that we continue to have many questions come through, but I also want to be mindful of the time that we've allotted for this webinar. As I sent out a message earlier, I encourage attendees to continue the conversation on our ACUI online community, and then I also do want to share that we will be sharing resources out to all registrants of our webinar, and we'll be sharing this video on our ACUI YouTube channel. I know we've got lots of questions coming in. This continues to be a topic that we'll be providing resources for on our end, and it is a true pleasure to partner with other associations as we try to tackle this topic. Any final words from any of our panelists before we depart today?
I would just say again, educate yourself, educate your students, educate your staff, and act evidence-based and data-based responses are very critical during these times. A lot of questions can be answered by the data and the information that is out there.
I would want to just make sure people are using the CDC website when questions come up. It's extraordinary how you can just type in 2 or 3 words and it takes you right to definitive information. The other thing to tell you about is that ACHA, just within the last 3 to 4 days, has published a document on the advice for colleges and universities regarding COVID-19. And yesterday, CDC published another document called Recommendations for Institutions of Higher Learning and COVID-19. And so these would be important documents, as suggested by Kat, to to take a look at. Keep educating yourself and then re-educating yourself, because the ground is shifting very quickly on this one.
I would just say strike a balance along with educating yourself, knowing the facts. I think in a campus situation, particularly when you're forward facing, it's how do you help folks prepare for what could be the worst if you have to go online remotely, if you have to do graduation remotely, things like that, without having people panic about that, because being prepared is really important, but doing it in a way that helps folks understand the reality of the situation today, which is that we're not there today. We may get there, and we want to be prepared if we get there, but how do we do so in a balanced way that doesn't have folks panic? That's the real challenge. So approach it with balance.
I want to say an enormous thank you, Dr. Michael Huey. Thank you for serving as a co-moderator with me and helping to post some of those questions to our panelists. Dr. James Jacobs, thank you so much for your time. Dr. Kat Marriott, Dr. TJ Logan, we could not do this without the resources that have been pulled together today. So thank you all for coming in and sharing your knowledge and expertise. We will keep this conversation going. Thank you, everyone.
Thank you.